you're going to see one such system now, which has learned a lot from across the globe, and then how we have taken eye care to a next level. I'll just try to share some of our experiences. So this, like in this year, we are celebrating our Golden Jubilee, which is 50 years now. It started in 1976. So now we have 8 tertiary care centers, 8 secondary care centers, and 8 community eye clinics. But we also run something called vision centers, where we really go into the rural area. So as we speak today, today we may be seeing close to 30,000 outpatients this Saturday, which is supposed to be our highest for whatever reasons in July. So by the end of the day, so today by this time, we have already crossed 19,000 outpatients across all our systems. And every day we do more than 2,000 surgeries, do a lot of camps. But what has really made this into a system is a lot of other things which we had to kind of build over the last 50 years, from just hospitals to kind of take the model across the globe called LICO. And then we have to have our own manufacturing facility to cut down the cost of the supplies. So we started Oro Lab, and now we are really into eye tech. We call it as Oro Eye Tech because of the need for information technology and AI. We have 110 engineers working in our Madurai campus. Can you believe? In an eye hospital, 110 engineers. So we have every field of people, right? Like people who have done MBAs to people who have done PhDs working with us. So like now we have more than 6,000 staff across the all the systems. And this is how our volume has been climbing over the last 50 years. Only that COVID year, we could take a small breath, right? We didn't know what to do, but we tried to do a lot of things which are innovative and which is also now helping us in a big way to tackle the volume. You see, post-COVID, the volume has significantly increased. One was because of the backlog, and the other reason was more awareness and more innovations we have done. So we are also generating more of a demand now. And this is the surgeries which we have done so far. So how are we able to do this? How are we able to serve almost 6 million people annually? And also most of it is steeply subsidized. Many of them don't pay. Many of them are steeply subsidized by the government insurance or through even private insurance.
The driving force behind it was Dr. Govindappa Venkataswamy, an ophthalmologist fueled by a compassionate vision.
He set out to cure blindness, not just in his own town or the state of Tamil Nadu, but for the entire world.
Here was a man who was able to look beyond the national boundaries, the religious boundaries, and look at every person and said, why should anyone be blind in this world?
So that is how he was. Even when he started a small eye clinic, a small hospital, he was thinking globally. How can we solve the problem of blindness? How can we eradicate needless blindness across the globe? And that is where he came up with a very powerful mission statement to eliminate needless blindness by providing kind of quality eye care for all. Wherever they live, whatever they can afford, we have to give the highest care. And that's where, like what Dr. Mananathan was saying, he was bringing in a lot of ideas from outside. The first thing when he went to US, when he was testing in McDonald's, he was so impressed by the system. Don't get into the junk and all that. It's the quality of the product, it's the pricing, and consistently, you get it in a very short time. So how can you bring such systems into eye care? He was always thinking like that. And there is a beautiful video, if you browse saying McDonaldization of eye care, you can see that and say how we learn from some of these models across the globe. So there are 7 pillars we call. All these are our pillars: making eye care accessible, quality care, centering around patient, being self-reliant, not dependent on any funding, more staff-centric, frugality, and sharing. Whatever you saw, the principles which were shared in the Tirukural, we follow everything. So we have kind of enabled access by keeping our OP open for a longer time so that anybody can walk in and register. There's no appointment system, and only appointments is for procedures like lasers and injections. So this is kind of, kind of enabling, bringing the bottleneck, opening up it, and so that more patients can get into this. I'm not going into this story, but basically Dr. V was learning everybody, from everyone, including this blind person. This story is there in our book called Infinite Vision and all that. So this person, Sambhavan, was having, he was begging in the front of Tirupparangundram temple, but over the years, he started becoming blind because of cataract. And Dr. V said, no, we are running a hospital, every service is free. Why don't you come and get your eyes fixed? You know what Sambhavan said? Your service may be free, but how do I access that? No, who's going to take me? Who's going to feed me? I am a beggar for the next 3-4 days. Those days, people used to be at hospital for almost a week. And this made him question. This said, no, we have to do something. And that is how he started the outreach. And he said, we'll bring you, we'll bus you, we'll drop you, we'll feed you. And that is how our eye camps became a big part of our daily activities. You can see a team like this going, setting up eye hospitals. So for everything, there was innovation. How to do refraction, how to kind of high volume care in some of these outreach. We had to innovate a lot. We had to bring a lot of frugal ideas. Because we need to sustain this week after week. We have to do significant volume. So we do all the tests in the eye camps, like measuring the pressure, looking at the nerves, screening for cataract. Everything is done in a campsite. And now you see outreach happens for a lot of things. But basically, Dr. V was the person who started outreach in healthcare, in eye care. So every year, we see close to 500,000 patients through these patients, 500,000 patients. So many people come, they are bussed in, and then they are operated, they send them back. But we needed something more concrete. We thought just camps may not help. So we need to have more concrete facility, which is which is easy to access. So it has to be in the rural or semi-urban area where they can easily access. And that is how we started something called the vision centers. It is something like your primary health centers, which government runs. So vision centers, now we have 120 centers seeing almost 1 million patients every month. So, you see, these are rural centers where there are a couple of staff. You can see in that video, one is called a coordinator, another is an optometry. So these two people see 40-50 patients every single day. So by doing this, we have seen more than 1 million patients last year in 25 and in the couple of previous years. The numbers have been gradually increasing, but everything is teleconnected. Now every patient gets telemedicine. So there is a doctor talking to him. Now we have technology where we can do imaging, we can do AI on those images to detect for diabetic retinopathy or glaucoma. So like you see this is called a fundus on phone. This is a technology which can easily image the back of your eye, and that there is also AI which is kind of inbuilt. So it can even offline work. You don't need online connectivity. And then you can do telemedicine with the base hospital. So what these centers have done is they have significantly...
Think getting a cataract surgery meant 3 long trips to the hospital? Yes, it did. Even with a vision center referral, the pre-op tests were repeated at the base hospital. Second visit would be on the day of cataract surgery, and third for post-operative day 1 evaluation. And then came the COVID. Vision was slipping away, not because of disease, but because of distance. And then single visit cataract surgery was born. Pre-op tests and post-op evaluation will be done at nearby vision centers itself. The patients have to visit the base hospital only on the day of surgery. By cutting down trips, we are reducing carbon emission. One visit, one goal, clear vision.
What started during the lockdown is our new normal. Better for your eyes and better for the earth. That's how we do sustainable healthcare.
So this is we learned during COVID. Now before that, we were making them come for pre-op and then surgery, post-op. Then we realized, why are they coming from a vision center here? We can do all the tests there. So we had to do a little bit of tweaking. We had to improvise on the system. And now it's a new normal. It's a new system which we have established where patient comes only on the surgery day. This is a article. Now it's a very popular article we published during COVID time. Now most of healthcare are now quoting this. How some of these centers are easily accessible even in a pandemic. See the hospital during the peak wave, there are only 40%, 50% coming to the tertiary centers like Tavalakuppam. Whereas to a vision center, almost 80% of people were going. This is at the peak lockdown when you had the risk of infection. So these are evidences now changing practices that some of these rural centers will make a big difference. And then the supplies were very expensive. And that's where we innovated that we need to do reverse engineering and we need to have an R&D and develop our own lenses and pharmaceuticals, which was established in 92. But fortunately, now 20% of global share is with Aurolab in ophthalmic supplies. So if you have 10 lenses globally, 2 lenses are from Aurolab, and this covers like 160 nations. And now this 10% has gone to roughly 18-20% now. So many of from just lenses, we have started making a lot of things. But Dr. V, from the beginning, when he started the hospital in 76 itself, he said, we have to train the world. The people did not realize what is meaning by training the world. He said, we have to bring them, show them how we work. And he started doing this way back in 1981. This is a picture taken in 1981. And this particular gentleman, I don't know if you've heard this name called Sanduk Ruit. He's a Nepali. He runs a Tilganga Eye Hospital. And he's got Magasase Award and all awards. He was a Padma Shri once when Indians had the foreigners get Padma Shri. So he's one of the initial people now who were trained by Dr. V, and they are running excellent organizations in Nepal now. Most of the Indian cataract surgeries are done in Nepal, in the border of UP, Bihar, and all that. And then he went to, he did eye camps in Maldives way back in 1985. We were on a ship to Maldives to go and do eye camps and operate. And that is how this institute started, Institute of Community Ophthalmology. It is to train people who are in eye care, train ophthalmologists, train the technicians, train people who are related to eye care, whatever job they do in eye care, like managing an eye hospital. So there is fellowships in managing eye hospital. So they go back and do a very good work in their own hospital. So see, basically we try to replicate the Aravind model in other places, like how you do franchisee, but we help the local players to come here and see whatever we have learned. So he was saying, Dr. V was saying, train your competition. Even if they are next door, you train, because your overall goal is to eradicate needless blindness. So they do a lot of training, research, advocacy, and a lot of things which help them to do better. And we have been involved in national programs like the National Program of Control of Blindness in different countries, or also we are involved. And then we do a lot of IT products, and this is also being shared, like our EMRs, our hospital management softwares, everything is shared. And we are part of, so where you're sitting is one of the WHO collaborating centers of the world. There are very few in eye care, and Aravind is one of the WHO collaborating centers. And a lot of courses by which we train people in short term, like 2 weeks, 4 weeks, how to maintain an equipment, how to be sustainable in your practice, how to manage an eye camp, how to do a good outreach, all these training.
Sala Uno is a social enterprise, and we are replicating the model of Aravind in Mexico City. The founders of Sala Uno, they contacted Aravind, came here, studied the model, and started to create the business model in Mexico. So far, we have provided 12,000 cataract surgeries, and Aravind is just telling us what they have done well. They share the numbers, they share their strategies, and I feel that's the right way to do. Because when it comes to healthcare, it's a right. It's a human right.
So nothing is protected. So no IP and no protection here, because we need to share our ideas. We need to take the best practices outside. So I'll just quickly finish my talk to just show how sustainable this particular place where you are sitting, the Pondicherry facility is. In general, we do all these things which normally they say as green practices, but more focused on how we generate. Almost 60% of the power what we use, at least in Pondicherry facility, is generated through solar, and we are still negotiating with the government for the rest. Like what you see is the beautiful drone for video of the facilities you see here, but a lot of renovation is happening. We are adding up operating rooms, but we have been always very sustainable at this campus for the last 24 years of our existence. So 65% of our energy is there. Water management, this has been a role model. There is DWATS plant. Almost 90% of your gray water is recycled and used for gardening and flushing the toilets now. And this is a seminal work which we did in 2018, which we published in a big journal, where we found that the waste which we generate for one cataract surgery is running 25 kilometers in your vehicle versus running 500 kilometers in the Western world. And this twisted a lot of people, a lot of eyebrows went up to understand what is really happening here.
Every surgery leaves something behind. In the West, one phaco generates up to 5 kilograms of waste. Here, at Aravind, it is just 250 grams. Same surgery, similar endophthalmitis rates. It's not about cutting corners. It's about mastering the pillars of reduce and reuse. We reduce by utilizing BSS to the end of the bag and cassettes to the end of the day, maintaining a continuous sterile flow across sequential cases. We reuse through IUSS and eliminate the need for mountains of single-use plastic. We do not throw away the kit, we reset the standard. One surgery, two distances, 500 kilometers versus 25. The math is simple, the outcomes are identical. The question isn't how we do it. The question is, why aren't you?
So when I talk about this, nobody listens now, especially the generation which is sitting in the back. That's why we had to create reels for all this so that we can share some of the reels in the media. So basically we are 20 times lower carbon footprint. But if you take the other problems, which we are really concerned about, the infection rates and all that. So these are all evidence-based. We have all published data to show that our infection rates are similar or even lower than. And more importantly, this is one thing which everyone can do, and we try to practice at least in eye care now, really segregating the waste at source, which we were doing many years back in our kitchens and homes, like even the newspapers, Tamil and English newspaper at a price, right?
A bloody iPad, yellow bin, used blade, tricky, white bin, and this mountain of cardboard I/O boxes and plastic lens covers? Well, throw it all in the corner.
We made a better spell. Aravind Eye Hospital cast the ultimate charm, deep segregation at source. We didn't just separate wet and dry. We went microscopic. Every specific material and size gets its own dedicated bin. Mixed trash gets the minimum price, but pure sorted waste is goldmine. Thick or thin plastic, big or small bottles, we divide and conquer to maximize our revenue. By segregating at the source like paper, plastic, and cardboard, we found only 15% is actual biomedical waste, the rest recyclable. This means less incineration, banished needle sticks, and saved labor. We transformed trash into a massive resource. And the results? Absolute magic. We generated 500,000 INR, enough to fund 500 subsidized cataract surgeries. It's deep segregation, where waste ends and vision begins.
So what we found was, if you can really segregate even paper and plastic, you can even generate more revenue from recycling. If you put everything together and send it for recycle, then he will take the least price of it because he doesn't know how many kgs of what is there. So what we realize, even thick plastic and thin plastic and color plastic is also important. Color plastic has got a lesser price because they cannot make a similar pellet with that. So this is a popular slide which is used across the globe by many ophthalmologists. They show this, like one case of cataract, and then 100 surgeries in Pondicherry. Now you can see how it is 20 times more waste they generate, and all this goes to landfill again, because everything is not biomedical waste. Only 15% is biomedical waste, and now several centers at least start segregating biomedical and non-biomedical. So this is how all the categories are done, and then this is a study which we did, and we published that. It can also, so whenever you're looking at your patients and whatever your customers, and then if you're friendly to the planet, you will automatically make profit. And that is what we have seen. And this is one last thing I will show you. This happens every day in Pondicherry. One of our fire officer, He enjoys doing this because he's passionate of
Why
this.
is everyone staring at a tree in an eye hospital? And what is his role here? Come on, let's get inside.
Inside our OR, it's all about high volume, precision, and perfect flow.
But what about the attenders outside the OR?
The waiting area blues, stressing, endless anxiety. And, meet Mr. Krishnamurthy, who took matter into his own hands. Instead of anxious waiting, he takes them to the green walk. This is a journey of sustainability. They learn about the importance of nature cover, sustainable power generation through solar panels, how we recycle water through DVATs to feed our gardens, and the art of reuse and recycling. By the time the surgery is done, the anxiety is gone and the time is well spent. Because here, we don't just restore vision, we restore the planet.
So I used to make 8-minute movies for conferences. This time they had a new category called Reels. So this reel won the Best Reel Award. Though I had submitted some 8 reels and this was one of the Best Reel Award. But basically now we have to move to really kind of make this quickly, right? So we know that we have to innovate, and that's where, again, during COVID, we started doing hackathons, and we do it for the last 6 years. And this January also we had, and we enjoy doing it. We enjoy working with some of the young minds, the engineers who come in, and then we have teams from VIT. Balachandran was also there, and then you can see how the team, when the doctors and engineers sit together, that is where real solutions are. It took a lot of time even for us to realize this. Then we realized we need to sit together like this. And then technology can help facilitate, whether it's AI or 3D printers, because they know exactly how it works. And they can draw, they can do your CAD drawing, they can make sure you think differently now. Sometimes I have a solution, I go into the room, and then the engineer comes up with a brilliant solution, an out-of-the-box idea, and then we have cracked it. So we have solved a lot of problems, and a lot of our innovations are now being also kind of patented and taken to the next level. But basically, I think this is a time where we all have to sit together and work. And this is one forum like that where we are meeting a lot of like-minded people. Thank you.